Headache and migraine. Etiology and epidemiology. Headache is a common symptom among children and adolescents. Headaches can be a primary problem, such as migraines or attention-type headaches. Secondary headaches are most often associated with minor illnesses, such as upper respiratory infections or sinusitis, but may be the first symptom of serious conditions, e.g. meningitis, brain tumors, so a systematic approach is necessary. Clinical manifestations. The temporal pattern, acute, recurrent episodic, chronic progressive, chronic non-progressive, is useful in the differential diagnosis of headache. Tension-type headaches are the most common type of recurrent primary headaches in children and adolescents. Because they are generally mild, without associated symptoms, they typically do not disrupt daily activities. The pain is global and squeezing or pressing in character and can last for hours or days. There is no associated nausea, vomiting, phonophobia, or phonophobia. Headaches can be related to environmental stressors or symptomatic of underlying anxiety or depression. Migraine headaches are another common type of recurrent headaches and frequently begin in childhood. Headaches are stereotyped attacks of frontal, bitemporal, or unilateral, moderate to severe, pounding or throbbing pain that are aggravated by activity and last 1 to 72 hours. Associated symptoms include nausea, vomiting, pallor, phonophobia, and an intense desire to seek a quiet, dark room for rest. Toddlers may be unable to verbalize the source of their discomfort and exhibit episodes of irritability, sleepiness, pallor, and/or vomiting. An aura can precede or coincide with the headache and typically persists between 5 and 60 minutes. Visual auras are common and consist of spots, flashes, or lines of light that flicker in one or both visual fields. Complex atypical auras, such as hemiparesis, monocular blindness, vertigo, confusion, that are accompanied by a headache warrant careful diagnostic investigation, such as neuroimaging and electroencephalogram. Common causes of secondary headaches include head trauma, viral illness, and sinusitis. Medication overuse headaches may complicate primary and secondary headaches. Serious causes of secondary headache include increased intracranial pressure, ICP, caused by a mass, e.g. tumor, vascular malformation, or intrinsic increase in pressure, pseudotumor cerebri. Increased ICP should be suspected if the headache and associated vomiting are worse when lying down or on first awakening, if they awaken the child from sleep, if they remit on arising, or if they are exacerbated by coughing, Valsalva maneuver, or bending over. Papilledema, figure 180.1, or focal neurologic deficits should trigger an intensive etiologic investigation. Diagnostic studies. For most children, a thorough history and physical examination provide an accurate diagnosis and obviate the need for further testing. Neuroimaging is usually not necessary. Imaging is warranted, however, if the patient has an abnormal neurologic examination, symptoms of increased ICP, unusual neurologic features during the headache, atypical aura, or progressive worsening of headaches. In these cases, brain magnetic resonance imaging is the study of choice, providing the highest sensitivity for detecting posterior fossa lesions and other more subtle abnormalities. When the headache has a sudden, severe onset, emergent computed tomography, CT, can quickly evaluate for intracranial bleeding. If the CT is negative, a lumbar puncture should be performed to measure opening pressure and evaluate for pleocytosis, elevated red blood cells, and xanthochromia to evaluate for a subarachnoid bleed. Treatment. Treating migraines requires an individually tailored regimen to address the frequency, severity, and disability produced by the headaches. Intermittent symptomatic, abortive, analgesics are the mainstay for treatment of infrequent episodes of migraine. Symptomatic therapy requires early analgesic administration, often accompanied by rest in a quiet, dark room. Acetaminophen or a non-steroidal anti-inflammatory drug, such as ibuprofen or naproxen sodium, is often effective. Hydration and antiemetics are useful adjunctive therapies. If these first-line medications are insufficient, triptan agents may be considered. Triptans, available in injectable, nasal spray, oral disintegrating, and tablet form, are serotonin receptor agonists that can alleviate migraine symptoms promptly. Based on theoretical concerns regarding increased risk for stroke, it is generally recommended that triptans be avoided for patients with hemiplegic migraine or migraine with brainstem aura.
Many children suffer severe and frequent migraines that disrupt their daily lives. Before initiating daily medications, lifestyle modifications, including increasing fluid intake, avoiding skipping meals, engaging in good sleep hygiene, and exercising regularly, as well as identification and elimination of any precipitating or aggravating influences, e.g. caffeine, certain foods, stress, missed meals, dehydration, are beneficial. Other adjunctive treatment options include psychological support, stress management, and biofeedback. Although there is limited data on the effectiveness of nutraceuticals, riboflavin and magnesium may be helpful for migraine prophylaxis with a low side effect profile. Children with more than one disabling headache per week may require daily preventive agents to reduce both attack frequency and severity. Preventive medications include tricyclic antidepressants, e.g. amitriptyline, nortriptyline, anticonvulsants, e.g. topiramate, valproic acid, antihistamines, e.g. cyproheptadine, beta blockers, e.g. propranolol, and calcium channel blockers, e.g. verapamil. The use of calcitonin gene-related peptide receptor antagonists is currently being studied in children.